The differential diagnosis of polyarticular joint pain in adults can be, well, daunting. Sure, we can order some non-specific labs or take some pictures, but it's often the history and physical exam that provide the most useful diagnostic information. Keep in mind that disorders classically associated with monoarthritis, such as crystal induced arthritis, septic arthritis, and Lyme disease, can, on occasion, cause polyarticular symptoms. But these etiologies will be saved for our upcoming monoarthritis sketch. Additionally, there are a number of disorders that are associated not only with polyarticular pain, but also prominent muscle and soft tissue pain, like fibromyalgia and hyperthyroidism. These too will not be covered in this sketch. Now, this doesn't mean that joint pain is the only symptom you should be looking out for. In fact, polyarticular pain may be the first manifestation of a systemic rheumatic or infectious process. This is why getting detailed history and complete physical exam is so important. Polyarticular joint pain, or polyarthralgia, is often used interchangeably with the term polyarthritis. However, deciding whether there's any appreciable itis at all is an important first step in our differential diagnosis. When evaluating a patient with joint pain, the first thing you'll want to establish is whether or not synovitis is present. In other words, is there inflammation within the joint or not? If the patient has symptoms and signs of an inflammatory process, you've already narrowed your differential to the inflammatory causes of joint pain. Symptoms suggestive of an inflammatory process include pain that worsens with immobility and improves with activity, those classic morning stiffness symptoms, symbolized here by the sad, stiff early riser next to this happy, active monkey. Constitutional symptoms such as fever, night sweats, and weight loss point to a systemic infectious or rheumatic process. Physical exam findings such as warmth, erythema, swelling, and tenderness indicate inflammation within the affected joints. During the joint exam, assess range of motion. Active inflammatory arthritis is associated with reduced active and passive range of motion. And finally, elevated ESR and CRP, though nonspecific, may indicate some sort of inflammatory condition. CRP is symbolized by the flying carpet, while ESR is symbolized by this wind chime resembling tubes of RBC sedimentation. With that in mind, let's run through the important inflammatory pathologies that can present with polyarticular pain. First of all, polyarthritis can often be the presenting feature of a systemic rheumatic or autoimmune disease, as illustrated by the immune complex shaped crossbar above this polyarticular puppet. The first etiology you probably think of when you hear polyarthritis is rheumatoid arthritis, which we'll abbreviate RA. RA is a progressive symmetrical inflammatory arthritis that, without proper treatment, leads to joint destruction and disability. At Sketchy, our recurring symbol for rheumatoid arthritis is an inflamed bone lantern, like this one here, held by this rheumatic marionette. There is a 2 to 3 times greater prevalence of disease in women versus men, with peak onset between ages 50 to 75. RA usually has an insidious onset and tends to affect smaller peripheral joints earlier in the course of disease, including the MCP and PIP joints of the fingers, the wrists, and the MTP joints of the toes. As the disease progresses, the elbows, shoulders, ankles, and knees are commonly affected. And that inflamed neck scarf is a reminder that the cervical spine is also common with long-standing disease, though the rest of the axial skeleton is typically spared. But not all the small joints are affected. One of the distinguishing features of RA is that it typically spares the DIP joints. So, on this marionette, you'll see that the large peripheral joints, as well as the small joints of the hands and feet, are highlighted in yellow. But the fingertips, the DIP joints that is, are spared. In the setting of active RA, patients commonly describe stiffness after waking in the morning or after long periods of inactivity. Yes, this is a common feature of all the inflammatory arthropathies, but with RA morning stiffness, it is more likely to be prolonged, at least 30 minutes, and usually involves the small joints of the hands or other affected joints. In fact, if these symptoms last for an hour or more, it's highly likely you're dealing with RA. Make sure to ask about the duration of symptoms. Symptom duration of at least 6 weeks is part of the diagnostic criteria of RA. Other criteria include arthritis involving at least one small joint or two large joints, elevated ESR or CRP, and fourthly, positive rheumatoid factors and or positive anti-citrullinated peptide antibodies, abbreviated RF and ACPA respectively. Up to 80% of patients with rheumatoid arthritis will test positive for RF or ACPA or both. RF is an autoantibody directed against the Fc portion of IgG, which we tried to convey in the design of her hat. To show anti-citrullinated, we made her necklace out of antibodies attached to citrus fruits. ACPA is more specific for rheumatoid arthritis, though both of these biomarkers are seen in several other autoimmune and infectious conditions. Progressive changes to affected joints can be seen on X ray, but you actually might not see much in early disease. With more long term disease, joint space narrowing and bony erosions become evident. Under this little X bones flag, we've incorporated the imaging findings within this Persian dome motif. Notice the eroding paint, as well as the narrowing joint space beneath the center dome. A few more distinctive signs of RA to keep in mind are rheumatoid nodules and joint deformity. But again, these manifestations are associated with more long-standing disease. Check out our dedicated rheumatoid arthritis sketch for all the details. The other major systemic autoimmune disease to consider in the setting of polyarthritis is systemic lupus erythematosus, which will abbreviate SLE. Not only do arthritis and arthralgias occur in the vast majority of patients with SLE, these symptoms are some of the earliest manifestations of the disease. Here are some clues that you're dealing with SLE rather than RA. While SLE and RA are both more prevalent in women versus men, lupus most commonly affects younger women. Disease onset is most common between the ages of 16 and 55. And while joint pain is symmetric, again similar to RA, the arthralgias and arthritis of SLE typically affects the knees, carpal joints, and fingers, especially the PIP. This distribution is the symmetrically scuffed knees and gloved hands of our precocious puppeteer. Notice that compared to RA, the ankles, elbows, shoulders, and cervical spine are less commonly affected. Importantly, the joint pain in lupus tends to be migratory. That means the joint pain comes and goes, and different joints are affected at different times. In fact, symptoms can even begin and resolve within 24 hours. So the wolf is walking, migrating, if you will. Also, SLE arthritis is typically non-deforming, as advertised on the sticker here. Keep in mind, however, that flexion deformities, ulnar deviation, and swan neck deformities can occur in some patients. This is due to joint laxity, however, rather than joint damage. The X-ray rarely shows any sign of erosion, and the deformity is reducible, as in you can move the joint back into position during the physical exam. If you're suspecting lupus in a patient with joint pain, you should always look for other characteristic systemic features, such as malar rash, oral ulcers, cytopenias, and renal disease. For the complete clinical picture, be sure to check out the teen lupus sketch. For now, we'll jump to labs. Almost all patients with lupus will have a positive ANA at some point in their disease course. But keep in mind that ANA is common in other systemic rheumatic disorders, including Sjogren's syndrome and even rheumatoid arthritis. Nevertheless, it's a sensitive test for SLE, and if it comes back positive, anti-double stranded DNA and anti-Smith antibody testing should also be performed. These antibodies are more specific for SLE. Now, before we move on, I just want to remind you that there are a wide variety of systemic rheumatic disorders that present with polyarthralgias and arthritis, and assessing for their characteristic systemic features as well as some key biomarkers, is often your best bet for nailing the differential. These dry, glandular looking rocks represent the dry mouth and dry eyes experienced by patients with Sjogren's syndrome, a chronic rheumatic disorder characterized by the autoimmune destruction of salivary and lacrimal glands. About 50% of patients with Sjogren will develop polyarthritis or arthralgias, but the picture is pretty similar to lupus. The arthropathy is symmetric, intermittent, non erosive, non deforming, and the hands, wrists, and knees are preferentially affected. Assess for the typical systemic symptoms and check for anti-Ro and anti-Law antibodies, though these can be positive in other rheumatic disorders as well. All right, let's move on to the infectious causes of polyarthritis. First up, the viruses. There are several viral infections that are associated with the polyarthritis syndrome, including Hep B, rubella, parvo, and enteroviruses. Compared to the insidious onset of RA, viral polyarthritis syndromes typically follow an acute time course, as illustrated by the cute little clock tower. It's falling, to remind you that these symptoms usually last only a few days to a few weeks. There's typically no bone destruction, and symptoms resolve without treatment. Symptoms ongoing for more than 6 weeks, along with negative serologic testing for viral infection, is more concerning for rheumatoid arthritis. As a general rule of thumb, an acute viral polyarthritis will present with other typical symptoms of acute viral infection, including sore throat, fever, and rash. Even with acute hepatitis B infection, polyarticular joint symptoms, when present, are commonly coincident with a maculopapular rash. Over in the parvovirus playset, I want to illustrate a few more characteristic features of parvovirus B19. Recall from Sketchy Micro that parvo or parvus means small because these viruses are tiny. In fact, they contain like 2 genes, and they're represented here by the tiny inhabitants of Parvoville. Most individuals with an acute parvo B19 infection will remain asymptomatic or develop nonspecific flu-like symptoms. About a quarter of patients, however, will have a disease called erythema infectiosum and or an acute polyarthritis. Erythema infectiosum, otherwise known as fifth disease, is the primary manifestation of parvovirus B19 infection in children. It causes a characteristic rash on both cheeks that is often referred to as a slapped cheek rash. Adults infected with parvovirus B19 are more likely to develop an acute polyarthritis, particularly women. The typical patient is someone with exposure to groups of children, think daycare workers or babysitters. Joint symptoms are often accompanied by a rash, so we've given the adult mannequin some rosy cheeks as well. Joint symptoms consist of an acute symmetrical arthritis of the wrists, knees, feet, and small joints of the hands, especially the MCP and PIP joints. Sound familiar? Sounds a lot like RA, doesn't it? Well, as we discussed earlier, it's important to keep the whole clinical picture in mind. Viral polyarthritis is acute in onset, often associated with other typical viral symptoms, including rash, and resolves in a few weeks. Serologies can be performed as well. In the case of acute parvovirus B19 infection, positive IgM antibodies against the virus establishes the diagnosis. Another group of viruses that cause significant joint pain is the flaviviruses, most notably the dengue virus, represented by this rubber dengue ducky. The dengue virus is found in the Caribbean, tropical Asia, and Central and South America, carried primarily by mosquitoes and transmitted to humans through a mosquito bite. Dengue fever is sometimes referred to as breakbone fever because of the significant muscle and joint pain that occurs during acute infection, along with the high-grade fevers. It can also present with a headache, retroorbital pain, and a rash. The diagnosis of dengue fever can be presumed if a patient presents with characteristic symptoms after having been to an endemic area within the last 2 weeks. Chikungunya, an alpha virus, is also notorious for causing polyarthritis. Like the dengue virus, it can be found in travelers who have recently visited the Caribbean, North, Central, and South America, and tropical areas of Asia. Disease manifestations are predominated by fever, rash, and myalgia, as well as a severe symmetrical polyarticular joint pain affecting any joint in the extremities plus the neck. All right, on to bacteria. Bacterial arthritis most commonly presents as acute onset of a single swollen, painful joint. So, bacterial arthritis will be covered more thoroughly in the monoarthritis DDX video. However, there are a few notable examples of bacterial infections that cause polyarthritis. In the setting of bacteremia or sepsis, for example, bacteria can invade multiple joints at once, causing an oligo or polyarticular arthritis. It turns out that joints already affected with arthritis are especially prone to bacterial seeding. So, polyarticular bacterial arthritis is most likely to occur in a patient with underlying rheumatoid arthritis or other systemic connective tissue disease. Disseminated gonococcal infection is another special case associated with two distinct clinical syndromes. So, let's take a closer look at this gonorrhea gondola, shall we? Less commonly, disseminated gonococcal infection results in a purulent monoarthritis. This is covered in more detail in our upcoming monoarthritis DDX video. The most common manifestation of disseminated gonococcal infection is tenosynovitis dermatitis polyarthralgia, also called arthritis dermatitis syndrome. As the name suggests, this syndrome presents as a triad of tenosynovitis, pustular skin lesions, and migratory polyarthralgias, as symbolized by the tendiny aquarium plants, pustular bubbles, and migratory arthritic shrimp, respectively. The tenosynovitis part manifests as tenderness along tendons, especially the tendons of the fingers, wrists, ankles, and toes. Disseminated gonococcal infection is the most common cause of septic arthritis in sexually active adults, especially in individuals under 40 with multiple partners or men who have sex with men. The original infection is typically an asymptomatic genital or pharyngeal infection. The joint involvement in gonococcal arthritis tends to be asymmetric, hence the asymmetrically weighted gondola tipping in the water. The ideal diagnostic test for disseminated gonococcal infection is isolation of the bacteria from blood or synovial fluid. Get at least 2 blood cultures, and if there's an accessible joint effusion, suck it out of there and perform synovial fluid analysis. Synovial fluid will show lots of leukocytes with neutrophilic predominance. Order a gram stain, culture, and nucleic acid amplification testing, which is more sensitive. Though keep in mind that arthrocentesis may not be possible because joint effusions are usually mild or absent. Patients with suspected disseminated gonococcal infection should also receive nucleic acid amplification testing on urogenital, rectal, and pharyngeal specimens. The next group of inflammatory polyarthritis is dubbed spondyloarthritis. Why the Eiffel Tower, you ask? The acronym PARIS is a useful mnemonic for remembering the major conditions that are associated with spondyloarthritis. This includes peripheral spondyloarthritis, axial spondyloarthritis, reactive arthritis, IBD-associated arthritis, and lastly, psoriatic arthritis. Yeah, technically psoriatic starts with a P, but how are you going to remember perip? These disorders were previously lumped together as the so-called seronegative spondyloarthropathies. By seronegative, we mean rheumatoid factor negative, hence the broken rheumatoid factor shaped crossbar. And while it's not technically true, up to 10% of patients with psoriatic arthritis can have a low titer of rheumatoid factor, for example. It's at least 100% true 90% of the time. And that's how we science. It actually is a good reminder that the lab abnormalities are mostly nonspecific and not useful for diagnosing spondyloarthritis. Instead, we need to keep the whole clinical picture in mind: clinical signs and symptoms, labs, and imaging. Let's start with clinical. Now, remember that these Paris spondyloarthritis conditions aren't separate categories per se. Instead, it's more like a big Venn diagram. and there are some important features that they all share, even though you won't necessarily see every feature in every patient. Spondyloarthritis literally means arthritis of the spine. This is one of the major shared features of the spondyloarthritis syndromes: inflammation of the axial joints, especially the sacroiliac joints. This is symbolized by the spondylosacroiliac Eiffel Tower. A common presenting symptom is low back pain lasting more than 3 months. These symptoms typically manifest before the age of 45. Kind of young for chronic back pain, isn't it? Most cases of spondyloarthritis related back pain will exhibit inflammatory features, including an insidious onset, worse pain at night, morning stiffness, and improvement of pain and stiffness with activity. Though keep in mind that inflammatory features are also pretty common in patients with other causes of back pain. What else can we look for? Well, in addition to back pain, many patients have peripheral joint pain, which usually manifests as an asymmetric oligoarthritis, with only 1 to 3 joints affected at a time, primarily in the knees and ankles. So, not only have we highlighted the typical lower extremity involvement with those pink joints, we've also made the legs asymmetrical. The onset of peripheral arthritis is typically acute, which is why we've added another one of those cute little clock towers. Remember, this is in contrast to the sacroiliitis and back pain, which presents insidiously. Now, many will present without these typical joint symptoms, so keep in mind that the absence of peripheral oligoarthritis does not preclude the diagnosis. Patients with spondyloarthritis may also have enthesitis, or inflammation of the enthesis, the insertion site of ligaments, tendons, or fascia to bone, depicted here by the red inflamed insertion sites of the puppet strings. The most commonly involved locations include the insertion site of the Achilles tendon, as well as the insertion site of the plantar fascia ligament into the calcaneus. Patients will typically have localized pain, tenderness, and swelling in affected areas. And one more musculoskeletal feature: dactylitis. Dactylitis refers to inflammation of the whole finger, as opposed to synovitis, which is inflammation of the joint. The diffuse swelling is colloquially described as sausage fingers, kind of like the bulbous sausage digits of this unfinished marionette. Dactylitis may be a feature of any spondyloarthropathy. However, as we'll soon illustrate, it's most commonly associated with psoriatic arthritis. Keep in mind that this is not an entirely specific finding and could also indicate sickle cell, sarcoidosis, or a variety of infections. Now, inflammation is usually not confined to the musculoskeletal system. Patients with spondyloarthritis may present with symptoms related to an ocular inflammatory disease, particularly conjunctivitis and anterior uveitis. Conjunctivitis is typically transient, but anterior uveitis is more serious, typically presenting as unilateral eye pain, redness, and photophobia, symbolized by this cracked red monocle. A slit lamp exam will need to be performed to get an accurate diagnosis. While usually responsive to topical therapy, some patients will develop recurrent or chronic disease with permanent vision loss. A couple more non-musculoskeletal features to highlight. Spondyloarthritis is associated with inflammatory bowel disease. Why not? We'll get into more detail in just a bit. Lastly, I want to point out the marionette's hat, kinda inflamed with a silvery scale on top, evoking an image of the classic psoriasis plaque. Psoriasis is associated with all forms of spondyloarthritis. Alright, how about them labs? You say bonjour, I say B27, as in HLA B27. If you suspect spondyloarthritis, test for HLA B27, which will be positive in about 90% of patients with ankylosing spondylitis, for example, and 50 to 70% of patients with the other forms of the disease. So, not the perfect test. It's okay-ish. Get an AP plain radiograph of the pelvis to assess for sacroiliitis, which is relatively specific for spondyloarthritis. Signs of sacroiliitis include SI joint erosion, sclerosis, widening or narrowing, and if severe enough, total ankylosis or fusion of the joint. Sacroiliitis is highlighted by these inflammatory sacroiliac fireworks underneath our recurring skull and X-bones flag. It's important to note, however, that it can take years before disease becomes evident on X-ray imaging. Imaging of the spine is typically not used to make the diagnosis of spondyloarthritis, but in the case of severe symptoms or for monitoring diagnosed disease, imaging can be performed. Spondylitis, or inflammation of the spine, is also relatively specific for spondyloarthritis. Characteristic findings include syndesmophytes, which are signs of ossification of the intervertebral ligaments. With long-standing disease, ankylosis or fusion of the vertebrae can occur, resulting in the classic bamboo spine. Back and joint pain that responds particularly well to NSAIDs within 24 to 48 hours is another pretty characteristic feature of spondyloarthritis. So let's add an inflammation extinguisher in the foreground here. Can't be too safe. Well, that's about it. That sums up spondyloarthritis. Now let's go through that Paris mnemonic, highlighting each of the conditions that are associated with this vast array of clinical features. Again, think of it as a Venn diagram. Each condition we cover has the potential to manifest with any number of these spondyloarthritis signs and symptoms. We'll highlight the important aspects of each disease that sets it apart. Jumpin' Jiminy, look at that bamboo! Patients presenting with predominantly axial involvement, that is, spine and SI joint involvement, are diagnosed with axial spondyloarthritis. This is usually a patient less than 45 years old with inflammatory lower back pain over 3 months and HLA B27 positive or sacroiliitis on imaging. If the sacroiliitis is seen on X-ray, it's officially called ankylosing spondylitis. If sacroiliitis is not seen on X-ray, but clinical suspicion remains high, get an MRI. Patients diagnosed by MRI are technically put into a non-radiographic axial spondyloarthritis category. Think of ankylosing spondylitis, though, as the especially severe form of axial disease. So, to sum up the clinical picture, we've got Pinocchio over here. He's young, he's got that tool jammed in his lower back, and he's next to an X-ray flag. In advanced ankylosing spondylitis that has progressed over years, spinal fusion can lead to severely restricted spinal mobility, restricted chest wall motion, and spinal deformity, particularly hyperkyphosis. Restricted chest wall motion can cause a restrictive pulmonary disease, and even in severe cases, pulmonary fibrosis. Ankylosing spondylitis is also associated with numerous cardiac pathologies, including disease of the aortic root, ACS, strokes, and conduction abnormalities. Aortic regurg is common, likely due to associated aortitis, which causes stiffening and sclerosis of the aortic outflow tract. The valve cusps retract and say, "Hello, regurg," as depicted by Pinocchio's stiff and permanently open aortic hat. Notice, too, that the jarring boop his growing nose is making sounds just like a diastolic aortic regurg murmur. Patients with axial spondyloarthritis are also prone to developing osteopenia and osteoporosis, which increases the risk of vertebral fracture. Now remember, even in the setting of ankylosing spondylitis, which is predominantly axial, any of those other peripheral spondyloarthritis symptoms can pop up as well. Common ones include peripheral arthritis, enthesitis, dactylitis, and anterior uveitis. All right, on that note, let's move on from axial predominant disease to peripheral predominant disease. There are 3 more syndromes to cover, each with a range of clinical signs and symptoms, overlapping with many of the classic peripheral symptoms of spondyloarthritis, including lower extremity asymmetric arthritis, dactylitis, and enthesitis. Starting with reactive arthritis, embodied by this apprentice reacting to the living puppet. The month calendar on his chest, along with the spilled diarrhea paint and bladder-themed oil lamp, should remind you that reactive arthritis develops 1 to 4 weeks after a bacterial GI or GU infection. It is due to an autoimmune reaction to the pathogen rather than invasion of the joint by the bug itself. Reactive arthritis is relatively rare and typically affects young adults, both men and women. A number of bacteria have been associated with reactive arthritis, but the most common ones are Salmonella, Shigella, Campylobacter, Yersinia, C. diff, Chlamydia trachomatis, and pneumonia, and E. coli, each depicted by their sketchy microsymbol, only this time as a miniature wooden figurine. Just remember the overall theme, GU and GI. Reactive arthritis presents as an acute asymmetric oligoarthritis that most commonly involves the lower extremity joints, such as the knees. Yep, the typical spondyloarthritis joint symptoms, oligo and asymmetric. Extra-articular manifestations are common. Kind of the recurring theme here, in case you haven't noticed. Ocular symptoms can occur and typically consist of conjunctivitis. Anterior uveitis is less common. Just think of all the other symptoms that go along with spondyloarthritis. Some patients will develop dactylitis or enthesitis, and even axial involvement with inflammatory low back pain and sacroiliitis. The diagnosis of reactive arthritis is made clinically. Assess for a previous infection. Look for the typical musculoskeletal symptoms and rule out the other big etiologies in this sketch. In patients with active diarrhea, get a stool culture. In patients with urethritis or suspected silent urethritis, chlamydia is a common pathogen. Perform nucleic acid amplification testing on a urine or genital sample. You can test for HLA-B27 antigen as well, which will be positive in 30 to 50% of patients. Next up, psoriatic arthritis, an inflammatory polyarthritis involving peripheral joints, axial joints, or both. About 70% of affected patients will have a history of psoriasis, and about 15% of patients with no known history will have signs of psoriasis at the time of initial presentation. Notice Geppetto's inflamed erythematous beret topped with some scaly plaque, reminiscent of a typical psoriasis plaque, discrete, raised, erythematous, and topped with silvery scale. Psoriasis affects men and women equally and can begin at any age. Psoriatic arthritis is associated with many different patterns of joint symptoms. It can present as an asymmetrical distal arthritis with DIP joint involvement, an asymmetric oligoarthritis, a symmetric polyarthritis similar to RA, or a spondyloarthritis with prominent axial involvement. In fact, these patterns often overlap, and patients who present with one pattern can develop a whole new pattern later in the course of the disease. Since an asymmetrical distal arthritis involves the MCP, PIP, and DIP joints, we've asymmetrically wrapped his fingers. Because of the usual day-to-day woodworking-related injuries. Dactylitis is a common feature, often referred to as sausage digits because of the diffuse swelling in the fingers and or the toes. Nail lesions are also common and include nail pitting, ankylosis, nail bed hyperkeratosis, and splinter hemorrhages, though these are also associated with uncomplicated psoriasis. Psoriatic arthritis is associated with characteristic patterns of joint destruction and deformity in the hands. On radiographic imaging, joint erosion, joint lysis, ankylosis or fusion of joints, and so-called pencil and cup deformities may be seen. Don't be surprised if joint lysis and joint fusion occur together in the same hand. All right, on to our last spondyloarthritis condition, inflammatory bowel disease associated arthritis. Most cases of IBD present in persons between 15 and 40 years old. There is also a second peak in disease incidence among 50 to 80-year-olds. A significant minority of patients with IBD will develop arthritis, including peripheral and or axial spondyloarthritis. The arthritis can be acute and remitting or chronic with flares. And keep in mind that other peripheral spondyloarthritis symptoms are common as well, including enthesitis, dactylitis, and anterior uveitis. Patients with spondyloarthritis and no documented history of IBD who develop chronic diarrhea, abdominal pain, weight loss, fevers, and or anemia should be referred to a gastroenterologist for a complete IBD workup. Assess for other extraenteric features of IBD, such as erythema nodosum, pyoderma gangrenosum, stomatitis, or uveitis. The most common skin manifestation seen in patients with IBD is erythema nodosum, which consists of violet colored raised nodules, usually located over the shins. It tends to develop when there is increased disease activity. The second most common skin manifestation is pyoderma gangrenosum, which presents as one or more very painful ulcerative skin lesions with violaceous borders and a purulent base. It usually occurs on the legs but can appear elsewhere and does not appear to correlate with disease activity. So, in summation, if a patient presents with joint pain and a history of chronic diarrhea, suspect IBD associated arthritis. IBD is definitely diagnosed via endoscopy and biopsy. Well, that got heated. Well, that about wraps up our discussion of inflammatory polyarticular arthritis. Time to finish off the sketch with the other category of polyarthritis, non inflammatory. Expect typical features of joint pain, limited range of motion, joint deformity, and mild swelling. This time, however, do not expect constitutional symptoms or significant warmth or erythema on exam. Inflammatory markers are typically within normal limits, though keep in mind that ESR can be elevated in a variety of unrelated conditions, such as renal failure, diabetes, paraproteinemia, or occult malignancy. The most common cause of non-inflammatory polyarthritis is osteoarthritis, which we'll abbreviate OA, a progressive degenerative joint disease characterized by destruction of articular cartilage. The pathogenesis of OA is multifactorial and thought to be caused by chronic wear and tear on the joint, in combination with abnormally increased activity of pro-inflammatory mediators and proteases. Yep, there is in fact itis in that joint. One of the strongest predictors of OA is age. Patients who develop OA tend to be older than 50. OA can develop after acute injury to a specific joint. This is called post-traumatic osteoarthritis and usually develops years after the initial insult. OA is also related to chronic injury or weight bearing, which can occur with excessive lifting, kneeling, climbing, whole body vibration, and repeated bending. Obesity is also a risk factor for OA, especially in weight bearing joints such as the knee and hip. Obesity is also related to osteoarthritis of the hands, however, which highlights the metabolic and inflammatory contribution to the pathogenesis of OA. Predictably, the pain in osteoarthritis becomes worse with activity or weight bearing, and expect symptoms to be worse in the late afternoon and evening. There may also be night pain that interferes with sleep. Morning pain and stiffness is common, but only lasts a few minutes. This is in contrast to inflammatory joint pain, which typically improves with activity and presents with prolonged morning stiffness. OA commonly affects the weight-bearing joints, particularly the knees and hips. OA also has a predilection for the first MTP joints, the facet joints of the lower lumbar and cervical spine, the first carpometacarpal joints, and the intraphalangeal joints, including the DIP. Notice that the two bulges on that phalangeal duster evoke an image of the PIP and DIP joints. When osteoarthritis affects the hands, it usually presents bilaterally and can closely resemble rheumatoid arthritis, though remember that rheumatoid arthritis typically spares the DIP joint. On physical exam, patients with OA will have hard bony swelling of the affected joints, a sign of bone and cartilage remodeling over time. This is in contrast to rheumatoid arthritis joints, which characteristically feel enlarged and boggy due to synovial thickening. Bony swelling that occurs in the fingers takes the form of Heberden and Bouchard nodes, affecting the DIP and PIP joints respectively. Interestingly, these deformities are more likely to occur in women and have a familial predisposition. The joint exam typically reveals a reduced range of motion, both active and passive. You may also hear crepitus with joint movement, especially in the knee. Diagnosis of OA can be made without the use of radiography in patients with the usual clinical presentation and age group. Patients with atypical features may require radiographic imaging of the affected joints. Look for the characteristic findings of OA. These nails jutting out from around the joint of the latter represent marginal osteophytes. Also assess for joint space narrowing. Definitely some bone on bone action in that joint there. Subchondral sclerosis is also characteristic of OA. It shows up as areas of increased bone density adjacent to the articular cartilage. At Sketchy, whenever we want to convey the idea of sclerosis, we use a scaly sclerotic snake, like this wooden toy snake here. Subchondral cysts may be seen as well, represented by those cystic marble eyes. All right, let's articulate the most important points. Assess for signs of synovitis to differentiate between inflammatory and non-inflammatory polyarthritis. Inflammatory arthritis is associated with morning stiffness that improves with activity, as well as constitutional symptoms such as fever, night sweats, and weight loss. Physical exam findings include erythema, swelling, and tenderness, and reduced range of motion of the joint. Lab values typically show increased ESR and CRP. One category of inflammatory polyarthritis includes systemic rheumatic diseases such as rheumatoid arthritis, lupus, Sjogren's syndrome, and numerous others. Rheumatoid arthritis is more common in middle-aged women. It affects smaller peripheral joints early in the course of the disease, including the MCP and PIP joints, the wrists, and the MTP joints of the foot. The joints are affected symmetrically, and the DIP joints are typically spared. Progressive disease attacks larger joints, such as the elbows, shoulders, ankles, and knees. Morning stiffness lasts over 30 minutes and often over an hour. Joint pain lasts over 6 weeks. Up to 80% are positive for RF or ACPA or both. Anti-citrullonated peptide antibodies are more specific. Characteristic findings on imaging in patients with long-standing disease include joint space narrowing, bony erosion, and joint deformity. Inspect for rheumatoid nodules. As for lupus, it affects younger women with disease onset between 16 and 55 years old. Joint involvement is symmetric, primarily involving the knees, carpal joints, and fingers, especially the PIP joints. The arthritis is migratory, transient, and non-deforming. If there are deformities, they are typically reducible. Check ANA, though it is nonspecific. If it comes back positive, test for anti-double-stranded DNA and anti-Smith antibodies. Viral polyarthritis syndromes are typically acute and self-limited without joint destruction. Assess for other signs of a systemic viral illness, including rash, sore throat, and flu-like symptoms. Parvovirus B19 infection specifically presents with acute symmetric polyarthritis in adults. The affected joints typically include the wrists, knees, feet, and small joints of the hands. Adults are at higher risk if they work in a field with frequent exposure to children. Serological testing for parvovirus-specific LGM antibodies can be ordered in acute infection if a definitive diagnosis is needed. Be sure to ask about recent travel. Flaviviruses and alphaviruses are transmitted by mosquitoes in endemic areas including Caribbean, tropical Asia, and Central and South America. Bacterial arthritis most commonly presents as acute onset of a single swollen, painful joint. But there are exceptions. In the setting of rheumatoid arthritis, for example, bacteremia can lead to infection of multiple joints. The other bacterial polyarthritis to look out for is disseminated gonococcal infection, which typically occurs in young, sexually active adults after an asymptomatic genital or pharyngeal infection. It presents with a triad of tenosynovitis, pustular skin lesions, and asymmetric, migratory polyarthralgias. Get blood cultures, Get a culture and nucleic acid amplification testing of synovial fluid. Get nucleic acid amplification testing of mucosal samples as well. Spondyloarthritis is associated with several conditions, including peripheral and axial versions of the disease, as well as reactive arthritis, IBD associated, and psoriatic arthritis. Spondyloarthritis typically presents in patients less than 45 years old, and symptoms include the insidious onset of low back pain with morning stiffness and improvement with activity. Peripheral symptoms include acute asymmetric peripheral oligoarthritis, particularly in knee and ankles, enthesitis, dactylitis, and ocular inflammatory disease, especially transient conjunctivitis and anterior uveitis. All types of spondyloarthritis are associated with psoriasis and IBD. The pain usually responds remarkably well to NSAIDs. Patients are generally HLA-B27 positive. Look for sacroiliitis on X-ray of pelvis, though that may take years to develop. If spinal imaging is pursued, spondylitis is a relatively specific finding. Syndesmophytes are characteristic. Ankylosing spondylitis is an especially severe form of axial spondyloarthritis, leading to spinal deformity, spinal fusion, reduced chest wall expansion, and even restrictive pulmonary disease within years. Ankylosing spondylitis is also associated with aortic regurgitation and increased risk of spinal fractures. Reactive arthritis occurs 1 to 4 weeks after a GI or GU infection. It presents with acute asymmetric oligoarthritis, typically in the lower extremity joints. Look for other common spondyloarthritis symptoms as well, including conjunctivitis. Psoriatic arthritis usually occurs in patients with a history of psoriasis. Patterns of joint involvement include an asymmetrical distal arthritis with DIP involvement, an asymmetric oligoarthritis, polyarthritis similar to RA, or an axial spondyloarthritis. Dactylitis and nail lesions, including pitting, are characteristic. Imaging findings include joint erosion, joint fusion, and pencil-in-cup deformities. And lastly, spondyloarthritis is also associated with IBD. Assess for the common extraenteric features of IBD and get an endoscopy with biopsy in previously undiagnosed patients. The most common cause of non-inflammatory polyarthritis is osteoarthritis. It is associated with old age, previous joint injury, repetitive or chronic injury, and obesity. The pain associated with osteoarthritis is worse with activity or weight bearing, and expect symptoms to be worse in the late afternoon or evening. Morning pain and stiffness can occur, but usually lasts only minutes. OA has a predilection for the first MTP joints, the knees and hips, lower lumbar and cervical spine, first CMC joints, as well as the PIP and DIP joints. Look for bony enlargement, Heberden and Bouchard nodes, limited range of motion, and crepitus in the knee. On imaging, osteophytes, joint space narrowing, subchondral sclerosis, and subchondral cysts are characteristic. And that's a wrap. That doesn't mean we're done with arthritis, though. Check out the upcoming sketch on rheumatoid arthritis for the complete rheumatic rundown.